it is my great pleasure to introduce now Professor Katrin Owen. And we know already what MODY is. We know that we are missing a lot of MODYs. And Katrin will teach us how to systematically search for them for their benefit. Katrin, the stage is yours.
I hope nobody holds me to this promise, but perhaps I can help in finding more people in your clinic. So I'd like to start off by introducing three patients that are pictured on this slide. First, two brothers, Neil and Robert, who are sitting there having a nice breakfast in our clinical research unit. And secondly, Leanne here, who's sitting with our diabetic specialist nurse. And these three patients, what they have in common is that they all have a mutation in the HNF1 alpha gene. And obviously they also have me as their personal physician, so they're very lucky. But in a way they are lucky because they have been diagnosed. But there was some considerable delay in their diagnosis. Both Neil and Robert, who were looked after by their general practitioners, were labelled as type 2 diabetes. And Leanne was labelled as type 1 diabetes. And the reason for that is that they didn't really fit what you might call traditional criteria for MODY sequencing that we've heard. They didn't fit traditional guidelines we've heard presented today. Both Neil and Robert were diagnosed over the age of 30. And although Leanne was diagnosed at the age of 21, she was very hyperglycemic and had ketonuria presentation, so she was assumed to have type 1 diabetes. But in none of these cases was the diagnosis reassessed at a time interval, so they were left with their original diagnostic label. So we've already seen this slide, and I won't apologise for showing it again because it shows the considerable regional variation in confirmed MODY cases that have been found in the UK. So the darker blue colours show more MODY. And of course, this is entirely correlated with referral rate, so that if you don't refer any patients, you won't find any cases. And so probably 90% of the UK MODY subjects remain unidentified, possibly more. And what we do also see is this very considerable delay in diabetes, in diagnosis of MODY after diagnosis of diabetes. And if we know we have a very effective treatment in the use of low-dose sulfonylureas, but we're not giving it to these people in those early days of diabetes where we know that maintaining good control is important, then we are really not allowing these people to have as good outcomes as they could. So what's the problem? Why is there so much misdiagnosis? Well, as we've heard today, it's very challenging sometimes to pick out these people because there's an overlap of clinical features with the common forms of diabetes, which would represent 95% of cases of diabetes. In the study that we've talked about on the number of cases found in the UK, it was reported that over 50% of the HNF1 alpha MODY subjects didn't actually fit that classic MODY criteria. So even if you investigated everybody who was diagnosed under 25 with a parental history and evidence of insulin independence, you would still not find most of your cases. So we have to spread our net a bit wider. And I think, as I've alluded to, one problem is that there's a considerable reluctance to question the original diagnostic label. So if somebody comes to your clinic, obviously everybody's busy, we don't have time necessarily to go through the notes. So if someone comes with a label of type 1, we often... oops. Sorry. I should have turned my phone off. So we're very reluctant to think again about what the diagnosis could be. So we've talked about why we want to diagnose MODY. We can get a treatment change. We find out about the prognosis, and we know that it involves the whole family. So there's clearly a good case for making these diagnoses. And how do we do it at the moment? Well, if we started with everyone with diabetes, as we've talked about, we've got a genetic test, but we can't afford to perform that genetic test on everyone. It's too expensive, and so we have to have some method of case selection. And we've talked about the standard clinical criteria in our guidelines. What I'm going to talk about today and in this session is whether we can extend these clinical criteria to define people who are atypical for type 1 or type 2 diabetes and what happens when you investigate those people. And tomorrow I'm going to talk about a development of biomarkers for MODY subtypes. So just first to comment on the standard criteria. These are really what you will call the low-hanging fruit. They're out there for us all to find. And here's an example. Julia, who's currently aged 47, and she presented at the age of 17. She had glycosuria. Her OGTT showed that she had diabetes with a large increment at 2 hours. She was lean. She was even treated for three or 4 years with glibenclamide tablets and then went on to insulin. And she had also had a family history. And then some 20 years later, she was diagnosed as having an HNF1 alpha mutation. And actually, at that point, she stopped taking insulin and went back onto sulfonylurea treatment. And she's very well controlled on that. So there's nothing particularly unusual about this case. What's unusual or unacceptable is that it took 20 years for her to receive her diagnosis. And so it's true that most HNF1 alpha families that you'll diagnose in your clinic will fit the current classic diagnostic criteria. The problem is they're largely diagnosed opportunistically. You see a patient and you think, well, they're a bit unusual. They don't have classic type 1 or type 2. But as I've said, not all mutation carriers fit this classic history. And within families, at least 30% are diagnosed over the age of 25. And we just don't know how many de novo mutations are out there because we tend to use family history as a very important criteria. So to talk about whether we can extend those criteria and find more cases. If you want to find cases of MODY, you actually have to look at different features for differentiating from type 1 and type 2. So if we just look at some of the features, HNF1 alpha, typically diagnosed between 15 and 40. You would expect one parent to have diabetes. You'd expect that they wouldn't have evidence of beta cell autoimmunity. Their C-peptide, as a marker of endogenous insulin secretion, is in the normal range. And because it's a beta cell defect, insulin resistance is unusual. If we contrast that with type 1 diabetes, well, the age of onset is pretty similar. It's less usual to have a parent with diabetes, but certainly it's commonly described to have a parent with diabetes. We would expect 80 to 90% of these people to have beta cell antibodies, especially at diagnosis. After the honeymoon period, C-peptide would be absent or very low. And again, insulin resistance would be unusual. So it's really the absence of endogenous insulin secretion which differentiates type 1 from HNF1 alpha. If we look at type 2 now, so we're seeing increasing numbers of types 2 diagnosed younger, but on the whole they still tend to be in the older part of this age range. It's extremely common to have a parent with diabetes if you've got young onset type 2 diabetes. 70 to 80% of adolescents or people in their 20s will have a parent or both parents with diabetes. Beta cell antibodies will be negative. C-peptide will be normal or high, and insulin resistance, as expected, will be frequent. So looking at this, the things that provide most sharp contrast is the older age of onset and the frequency of insulin resistance. So if we look at those sort of pathophysiological features, we can then define people who are atypical for type 1 or type 2 to select out. So I'm going to give you some results from our study in Oxford, which is a collection of subjects diagnosed before 45 years who've got a clinically defined either as type 1 or type 2 diabetes, and this is the sort of assumption and dictates their treatment. And the aim of the study was to select subjects for sequencing of HNF1 alpha or 4 alpha MODY using extended criteria based on pathophysiology, and to compare these extended with the standard criteria and see what the performance is like. So just to take you through the two parts of the study, if we start with those who've got a clinical diagnosis of type 2 diabetes, they're all diagnosed under 45 and they're beta cell antibody negative. So first of all, we picked out the people who did fit the standard clinical criteria, so diagnosed under 25 with 2 generations of diabetes. We then picked out, sorry, I went a bit too fast then, but we then picked out people diagnosed under the age of 30, so who had a particularly young age of onset. We then picked out people who could be diagnosed up to 45 but had no evidence of metabolic syndrome, and people who fitted one or more of those criteria had HNF1 alpha or 4 alpha sequencing, and obviously there was some overlap between these different 3 groups. For patients who were diagnosed over 30 and had metabolic syndrome, we didn't investigate them any further and assumed they had type 2 diabetes. Now, for people who had a clinical diagnosis of type 1, we took people who were post-honeymoon period with a duration of diabetes of 3 to 20 years. And in these people, we wouldn't expect them to continue to make C-peptide. So our first stage was to measure a random C-peptide just in the afternoon in the clinic. And if they had a C-peptide which was below the level of our assay, which is 0.09 nanomoles per litre, we assumed they had no significant endogenous insulin secretion and had type 1 diabetes. For those who had detectable C-peptide, we then offered them a more formal assessment of their insulin secretion with a glucagon stimulation test. And this is where you give a milligram of glucagon intravenously, and you take blood at baseline, a fasting C-peptide, and then a C-peptide at 6 minutes to see what the rise in C-peptide is. And generally, a rise of greater than 0.2 nanomoles per litre is considered to represent significant endogenous insulin secretion. So if we had people who had a random C-peptide that was low, less than 0.2, and they also had a very low increment on their glucagon test, we again assumed that they had type 1 diabetes. Now, because we wanted to be as inclusive as possible, we defined two definitions of residual beta cell function. One, if they had a glucagon stimulated test increment of greater than 0.2, and then if they had a bit of a more intermediate increment, but they still had a good random C-peptide of greater than 0.2, then we said they had residual beta cell function and sequenced HNF1 alpha 4 alpha in those people. And for those who we couldn't get to agree to come up for a glucagon test, but who'd had a random C-peptide greater than 0.2, we also sequenced HNF1 alpha and 4 alpha in those people. So if I go on to the